My name is Nasib Bowden. I sit on the board of MCP3, or Michigan Center for Progressive Public.
It's on the board.
No, it's Michigan Center for Progressive Public Policy.
I always say Midland, sorry.
Yeah, we want to encompass the whole state. The center was established to conduct policy research on matters affecting the quality of life in Michigan for its citizens and its visitors. We aim to develop and promote public policies consistent with the traditional American values of public education, equality under the law, cooperation between the government and free enterprise, including sustainable labor practices, stewardship of the environment, and promoting public health. We realize that each of these topics is interrelated. A well-educated citizenry tends to be healthy. They tend to be productive members of our society and can contribute to the betterment of our society by being responsible voters, as we've seen the last few elections. An uneducated citizenry tends to vote with minimal information. Voting responsibly, working faithfully, and giving back to their communities. Today's symposium is centered around healthcare. We have two speakers tonight, and it's my great pleasure to introduce our first speaker, Dr. David Green, who is a two-time graduate from the University of Glasgow, where he was awarded a bachelor's in science and medical degree. In between that, he completed his master's in science at Aberdeen University and PhD ABD at Edinburgh University. Edinburgh. Okay, sorry, I'm not very familiar with Ireland. David trained in medicine in Scotland and completed his residency there before moving to Australia, where he worked in a rural hospital as an ER physician. David now lives in the US with his family and is a naturalized citizen. He teaches college, where he writes about health and wellness for the college newsletter, and is prepared to re-enter the medical field by retraining as a PA. His ultimate goal is to run a free clinic in the north of Michigan. He'll be discussing the history of healthcare and introducing the various medical systems in the US and around the world. As you can tell, he's been traveled extensively. And perhaps the most important note, he's also a mediocre tennis player, but a wonderful friend and fellow board member of MCP3.
I've honestly never had an introduction as thorough as that before, and possibly also as honest. Talking about healthcare tonight, we're going to do this in...
The mic is a little bit closer to you.
I need to speak louder because this mic is actually for the camera and it's not projecting across the room.
Okay.
So I'll just try and speak with my teaching voice.
There you go, that's good.
Okay. So what we're going to do tonight is look at the past, present and future of healthcare across America, and hopefully with a bit more focus, particularly in the second talk, on Michigan itself, because there are obviously subtle differences between federal level and state level. But I think if we're going to think about what's happening in healthcare in America today and what's coming toward us in the future, we first need to understand how we got to where we are. So this first talk is a very brief look at the different systems that currently exist in the American healthcare market, when they came about, how many people they're roughly covering, and how they actually interrelate potentially to other healthcare systems around the world. So let's see if this is going to work. So here in Michigan, history of healthcare has its roots at the University of Michigan, which started out in Detroit and after 20 years moved out to its current situation in Ann Arbor. It opens its doors for its first medical school back in 1850, so 170 years so far have passed of Michigan producing its own set of physicians. Of course, the systems that they were practicing in for the first 100 years of that was basically a out-of-pocket payment system, and then changes came in after that. After the 50 years in the 1900s, when the American Medical Association became preeminent in the medical field, then that type of, their influence, started to fashion how the American medical market would then become. So around the world, there are about 44 countries in the world that have a universal healthcare system, meaning that everyone has access to it. Of that, there are three main systems that prevail. The Bismarck model from Otto von Bismarck is a multi-payer system, and it was basically a setup of sickness funds. The difference is similar in a sense to a lot of the insurance coverage that we have here in America, as I'll mention in a minute. But the big difference is that it's the government is the person that pays the bill. So therefore there is one large player, but many multiple players that feeding off that. What that means is that the government doesn't have to pay for the physical structures of the hospitals, the medical practices, etc., or the training of the specialists that work there. However, they do control how much money is flowing through the system. The Beveridge model came about after the Second World War as part of Britain's welfare state, which was a thank you to the population for surviving and putting up with everything they had to in the Second World War, because Britain, of course, at that time was not in a perfect position to repel a large fly, yet alone Nazi Germany. The Beveridge model is a socialized model, and this was the first of the single-payer systems that came into being. The UK, Spain is another country that also uses this type of model, and basically the government is in control of all aspects. It builds the hospitals, it creates the medical practices. The only independent parts of this are the general practitioners, and they are paid by the government based on how healthy their population are, so they have an incentive to do good sometimes. Single payer or national health insurance model is the Canadian system, and Australia is obviously similar as well with this one. And this is where, again, there's a separation between the government and what the facilities that are actually being used, but it's a single payer, so the government is in control of most of the costs of this system. The thing that keeps all of these systems together is it's universal. And that's an important point to make here, in the fact that every citizen of each of these countries that are covered from the day that they are born to the day that they die. The American system is the only system in the industrialized world which doesn't cover all of its citizenry in terms of healthcare. And so we still have the conversation of whether healthcare in America is a right or a privilege. Other industrialized nations have decided it's a right. So what do we have in the American healthcare system? Well, starting back in about the 1850s, when the first insurance policies were starting to be created for healthcare, we have the out-of-pocket or direct pay, which was around before then and still exists to this day. If you happen to have no coverage in America, then this is your option, and this is the same option as the rest of the world, which doesn't have universal health care. Veterans Health Administration, I'll talk about in a minute, along with the others, came next. Then employer-sponsored insurance grew out from the 1920s onwards, and Medicaid, Medicare came to us in the 1960s under Lyndon B. Johnson. CHIP, which is the children's coverage, which is sort of an extension of Medicaid, came out in the 1990s. After the failure of getting universal health care in the Clinton administration. And of course, at the end of this, in 2010, we have the Affordable Care Act, which our keynote speaker, Megan Foster Friedman, will be talking about in a few minutes' time. So I'm going to leave that one alone. So out-of-pocket or direct pay, as I said, since time immemorial. This is the way that, it says you go and buy your loaf of bread at the local supermarket, you pays your money, you get your loaf of bread. We still have about 15% of the American population at this point. Unfortunately, medical health coverage these days and procedures cost more than the average loaf of bread, so this is not a good system for most of that 15%. And as I said, it's equivalent to countries that don't actually have an organized healthcare system. The Veteran Health Administration, this was established in 1946 in its current state. It did kind of exist for about 20 years before that, but in 46 it became a solid thing which has lasted since. It covers about 5% of the population, and this is the one part of the healthcare system in America which actually mirrors the British National Health Service, which I trained in, or the NHS, because it's part of the Beveridge model. And this is the fact that in the VA, everything is covered. They have the facilities, they control the facilities, etc. Keep hitting the wrong button. Employer-sponsored insurance. This came around after World War II, while at the same time in Britain we were developing the National Health Service. The employers, obviously many millions of Americans have left America to come to Europe to fight in the war. This dropped the number of available people for work, etc., and the employers wanted to find incentives to bring them back into their workforces. One of the ways that they achieved this was through sponsored insurance, giving them coverage of healthcare for the first time. At the current time, we cover about 56% of the population are accessing healthcare through employer-sponsored insurance. Its setup is structurally similar to the Bismarckian model in that it's a multi-payer system. The difference is that the government is not sitting there and setting the prices, so the prices are left in what could be described as the free market. But as I want to talk about in the third part of tonight, the free market is not functioning correctly within the healthcare service. One of the other aspects, of course, about an employer-sponsored insurance is that if you're not old enough, if you don't have a job, or if you've retired, you're no longer part of the system. Medicaid. And we could talk about Medicaid and Medicare together, but I decided to separate them because there are subtle differences between them. Both established in 1965 under the presidency of Lyndon B. Johnson. Medicaid currently is almost covering 20% of the population, or about 70 million Americans. It has a lot of similarities to the NHS Beveridge model, but again, in the infrastructures, it's something not necessarily covered by the government, but certainly the costs and access are. Whereas Medicare, again established at the same time, covers almost as many people, 17.2% in the last, and this is all coming from the last census. But only 1 in 10 people that have Medicare completely and utterly rely on Medicare. They use other insurances to top that up. This runs in a very similar way to the Canadian medical model, and this is the one that's obviously been pushed, as we'll talk about a little bit later, as a potential expansion of this to actually give us complete coverage. CHIP, or Children's Health Insurance Program, came about in 1997, covering currently about 9 million children. There's more children being covered by that through the Medicaid system as a whole. Again, follows a similar pathway to the Beveridge model, the British system. I kept in a notable quote here because obviously a lot of people who are thinking and talking about health care, you don't usually have someone of the name of Orrin Hatch saying nice things about looking after people, and certainly not in recent years. But during the 90s, he actually came together with Senator Ted Kennedy to actually bring this to fruition. And they were called the Odd Couple as a result. All right, to finish off, the Affordable Care Act, or Obamacare, as many people refer to it, established in 2010 under the presidency of Barack Obama, currently covering 9 million people. It's trying to catch the people that do not get into the market through any other means. And again, because of that, is close to the Bismarckian model because it's still relying upon insurance exchanges to give the people the coverage. And that's my thing. So I'm going to click out to exit. That's the end of the first talk to give us an idea of what's been going on and where we've got to. I want to take a step back now and allow Megan to come to the stage and give her talk. Megan Foster-Friedman is our keynote speaker tonight. She has a master's in public policy. She has done many things down in Washington, I believe. And you worked for Senator?
I did, yes.
Was it Patty Murray? Patty Murray, yes. You worked for, and you're now a senior analyst with Chart.
Mm-hmm.
I'm going to let her do it because it's changed and I can't remember what it is, and I'm going to make a fool of myself if I haven't already. So I'm going to try not to do that and let Megan tell you herself. They do a lot of good policy research, and she's going to talk about the Affordable Care Act and how it's affected Michigan. Now, let's see if I can bring your talk up.
I'm actually going to use the other one. It's fine.
Oh,
We'll get it.
you,
All right. Great. Thank you. Thank you very much, Dave, and thanks to MCP3 for having me here tonight. Like Dave said, my name is Megan Foster Friedman. I'm a senior analyst at the Center for Health and Research Transformation. CHART is a much shorter and easier way to say it. But we are a nonpartisan, nonprofit health policy center based at the University of Michigan. And in addition to policy analysis, we also do a lot of survey and evaluation work, data analytics, and some community implementation. But one of the things that we frequently do at CHART is track changes in healthcare both in Michigan and nationally. And so I'm going to spend about the next 30 minutes or so talking about the Affordable Care Act. And this is a really, really timely opportunity to reflect on the law and where we've been, because the ACA just celebrated its 9th birthday. It was 9 years ago, 1 month and 1 day, on March 23rd, 2010, that President Obama signed the Affordable Care Act into law. And since then, it really has changed a lot of our nation's healthcare system. But the reality is that while the ACA is a very significant and wide-ranging law, it's also largely incremental. A couple of the main goals that law had were to expand coverage in both the private sector and the public sector, but it built on systems that already existed. It corrected some problems in existing insurance markets, and it included quality and cost strategies. But it wasn't a complete overhaul of our nation's healthcare system, and it really was never intended to be. It was always framed as the first step on a road to universal coverage. So when we think about the ACA and all it's done, it's important to remember that it is this incremental process working towards expansion of coverage. That said, now that we're 9 years into the implementation of the law, it really has become fully woven in our health system. It's impacted millions of Americans, both in Michigan and around the country. And it's also turned out to be surprisingly resilient. It has not had an easy start to life. In its 9 years, it's faced challenges in the court system, challenges in Congress, technical difficulties with healthcare.org, healthcare.gov, and a variety of attacks. So it's really almost surprising to me that here we are in 2019 talking about the ACA, which remains standing and, at least in some places in the country, remains very robust. So what I do best is, talk about data and impact in Michigan. So I hope you'll forgive me because I'm going to go through some graphs, but I think they really do illustrate just how much of an impact the ACA has had in Michigan. And one of the easiest ways to measure impact of healthcare proposals is by looking at changes in coverage. So the best way that we can do this in Michigan is by comparing sources of healthcare coverage from 2013 to 2017. And this is because many of the major provisions of the Affordable Care Act, things like expansion of Medicaid, creation of the health insurance marketplaces, those all came into effect in 2014. So we've got a nice before and after look. This is all from the census. And we can see that, in 2013, about half of Michiganders were covered through employer-based coverage. You had about 4 to 5% in this direct purchase pie. These are people who are in the individual market directly buying their coverage from insurance companies. Medicare covered just over 1.1 million Michiganders. Medicaid covered another 1.5 million. You had a couple of other categories of coverage, and then you had a large chunk of the pie that was uninsured. Over 1 million Michiganders were uninsured in 2013. Flash forward to 2017, and to me the most remarkable thing is that this pie has not changed all that much. You still have about half of the state getting coverage through their employer. You have a small increase in the direct purchase market. That's because of the creation of the health insurance marketplaces. A little bit of an increase in Medicare, an increase in Medicaid because of Medicaid expansion. But to me, the most significant change is that we've been able to cut our uninsured population in Michigan by half since the Affordable Care Act was passed. And if we look at it on sort of a timeline, you can really see the significant drop in the uninsured rate, both in the US and in Michigan after the Affordable Care Act was passed. You see from 2009 to 2013, things sort of held steady. In Michigan, our uninsured rate was anywhere from 12% to 11%. That began to fall precipitously in 2014 when we had these coverage expansions take effect. And in 2017, which is the latest data we have, just over 5% of Michiganders were uninsured, and almost 9% of the US population as a whole was uninsured. So we're still not at universal coverage, but the ACA has made some really great strides to expand that coverage. And the reason for the drop in the uninsured rate, we can look at some different sources of coverage to kind of tease out what is driving that decrease. But it's really not changes in employer-based coverage. We saw on that pie chart that things have remained relatively steady in the past 5 years, and this, pretty much remains true depending on the size of an employer. So this graph looks at employer-based coverage in Michigan from 2006 to 2017 based on employer size. You can see that large employers, for the most part, have almost completely provided healthcare coverage to their employees for all this time. Mid-size employers a little bit less likely to provide coverage, and then small employers, depending on the size, could be far less likely. We've seen some fluctuations in employer coverage, but a lot of it was starting to happen before the ACA was passed, and we think that a lot of it could be explained just by economic cycles as opposed to policy changes. So in terms of what's driving the uninsured rate, it's not so much what's happening in the employer market. What is contributing to that drop is the creation of the health insurance marketplace. This was one of the main provisions of the Affordable Care Act. It's really become synonymous with the Affordable Care Act. And the individual insurance market existed prior to the ACA, but the ACA aimed to make that coverage more accessible and more affordable to residents. And it also created health insurance exchanges, which are now known as the health insurance marketplace. This is an online platform, healthcare.gov, where people can go, compare comparable coverage across carriers, figure out what coverage they like best, and get financial assistance to help pay for that coverage if they qualify. So as of right now, we have just under 275,000 Michigan residents who have marketplace coverage in 2019. The vast majority of those people are receiving tax credits to lower their premiums. So we've seen some fluctuations in this market over the past couple years. We had a pretty substantial increase in enrollment from 2014 to 2016, where we peaked at about 345,000 people. Enrollment has dropped slightly since then. That's largely been a result of different policy changes that are happening in DC and rippling out across the country, and I'll talk about some of those in the middle of my presentation. But and the other thing I'd like to talk about is, there's this notion when we talk about the Affordable Care Act, every year you hear press coverage of premiums that are skyrocketing and places in the country where there's absolutely no choice of plans of carriers. And in some instances, there's some truth to this. There are some areas in the country that don't have robust competition on their marketplace and do have very high costs. We're finding in Michigan that's not necessarily the case. We do have a fairly robust health insurance marketplace. Since the beginning of the marketplace in 2014, we've had a variety of insurance carriers offering coverage. We had 9 carriers offering coverage in 2019. And we've also had a variety of plans too. It's fluctuated a little bit as companies have figured out this market and what consumers are responding to. But in every county in the state, people have at least 2 carriers to choose from and plans at a variety of different coverage levels. So when we look at the health insurance marketplace, when we think about Michigan, it really has been a success story. But the bigger success story of ACA, and what I think is one of the signature accomplishments of the law, is the expansion of Medicaid. Here in Michigan, that's known as the Healthy Michigan Plan. We launched our Medicaid expansion on April 1st, 2014. And we've seen a big increase in Medicaid coverage since then. Prior to the expansion, there were about 1.9 million people in Michigan enrolled in Medicaid. Right now, almost a quarter of our state is covered by Medicaid, either through the traditional Medicaid program or through the expanded Healthy Michigan Plan, which is available to adults age 19 to 64. And what's really remarkable about this coverage expansion is that a lot of people who are enrolled in Healthy Michigan did not have access to coverage beforehand. Almost 4 out of 5 Healthy Michigan enrollees earn less than 100% of the federal poverty line. That's around $12,500 a year for an individual. And many Michiganders, about a third of Michiganders at that income level, were ineligible for Medicaid before the ACA. So for this group of people, this is a new coverage option that they did not have access to before. But Medicaid expansion has had impacts not just on our own individual coverage, but on Michigan's economy as a whole. Some research conducted at the University of Michigan a couple years ago found that the Healthy Michigan Plan created 30,000 new jobs annually in our state and $2.3 billion in additional personal spending power. All of that added economic activity created $150 million annually in state tax revenue. And in 2017, that revenue was almost enough to cover all of the state's share of Medicaid expansion costs. So this is an investment that is really paying off for our state. We can also look at some changes in financial stability in hospitals in Michigan. Uncompensated care in our hospitals has fallen by half from 2013 to 2016. And when I say uncompensated care, I'm talking about hospitals providing coverage that they never get paid for. They're either providing charity care for free or very low cost for their patients, or they're unable to collect on hospital bills. So the amount of that kind of care that Michigan hospitals are providing has fallen precipitously, and it's because more people are covered by insurance than were before. But there are a lot of other significant provisions of the ACA beyond the health insurance marketplace and beyond Medicaid expansion. And I think it's important to talk about the very wide reach of the law when we think about where we've been and possible future directions for healthcare in America. Because the ACA was about coverage expansions and about affordability, but it included a lot of other strategies too. There were many programs in the ACA aimed at reforming health systems and healthcare delivery, different innovations like accountable care organizations and the state innovation model that look to transform the way that we receive our healthcare. Also a lot of quality strategies like the Hospital Readmissions Reduction Program and Hospital Acquired Condition Reduction Program. Those are both efforts to improve the quality of care. There's also a substantial focus on public health, both looking at prevention and public health workforce, and more of a focus on population health, looking at the health of our whole community as opposed to you as an individual in the exam room. And a lot of that is tied into a focus on prevention and wellness. The ACA mandated coverage of a lot of benefits that insurers were not required to cover before. These are things like 10 essential health benefits. These are categories of services that just about every plan on the market today has to cover. Things like hospital services, ambulatory care, laboratory services, mental health coverage, preventive services for women and for a variety of screenings, and a national prevention strategy. And people are using these benefits to a great deal. We at CHART did a survey of Michigan consumers last year looking at Michiganders' use of health benefits covered under the ACA. And we found that nearly all of the respondents to our survey were using one of the benefits listed on the sheet here. But preventive services, preventive doctor visits, things like your annual checkup, your screenings, was the most popular benefit. Over 80% of Michiganders were using those benefits. And in addition to benefits expansion, the ACA put in place a lot of market reforms to help correct some of the market failures that we were seeing, particularly in the individual market before the ACA. And I like thinking of these market reforms like a three-legged stool. And this is not my idea. I'm stealing this from Charles Gaba, who is a healthcare analyst based in Metro Detroit, but I just really like the way that he talks about this notion of the three-legged stool. So if the ACA's goal was to have affordable, accessible coverage to everyone, there were 3 pillars that had to hold up that notion. The first leg of the stool is insurer responsibility, and these are provisions like guaranteed issue and community rating, which means that everyone can purchase health insurance regardless of what their health is or their pre-existing condition, and premiums only vary based on your geographic region. All of those things are on the case of the insurer to make sure that people have access to the market. But if you only have that leg, then what ends up happening is you have a lot of people rushing to buy coverage who really need it and who use a lot of healthcare services. That alone would drive up premiums in the market. So in order to keep premiums low, you add in the second leg, this enrollee responsibility. And in the ACA, that takes the form of the individual mandate, which requires everyone to buy insurance. This means that a lot of people are getting into the market. You're spreading risk across a big pool. You'll have some people that use a lot of healthcare services, but some people that won't. And so you're kind of making the pool big and keeping prices lower. Now, the individual mandate has seen some changes in recent years, and I'll talk about that in a little bit, but that is sort of the pillar of the second leg of the stool. But even then, even with guaranteed access and a requirement that everyone buy health insurance, some people are still going to have a hard time affording coverage. And so that's where the third leg comes in, this government responsibility. And in the ACA, that takes the form of tax credits and cost-sharing reductions, financial assistance to make coverage affordable. So the ACA has done a lot to standardize the market, make plans more comprehensive, more comparable, and more accessible to everyone. Today, this three-legged stool is still largely standing. It's had some chunks taken out of legs here and there. It might be a little bit wobbly, but all in all, it's still there. And when I look back on the past couple of years, it's pretty remarkable that it's been able to, to weather all of that. And so speaking of looking back over the past couple years, I'd like to finish this off by talking a little bit about what's happened to the ACA in the past couple of years. We'll talk about some recent policy changes and those specific impacts in Michigan. So this is a wild ride. Hold on. Flashback to 2017, that we have a new administration in Washington, a Congress that is controlled both chambers by the Republican Party. And in 2016, the Republican Party and President Trump were campaigning on health care. And their main priority was to repeal the Affordable Care Act and replace it with an alternative. So we spent 2017 debating all of those repeal and replace efforts. I also like to call this the summer of my discontent, because I was tracking all this in a real-time basis, and it was chaos and a lot to deal with. So you started out in the House of Representatives. They actually passed a bill of their own. It was called the American Health Care Act. That passed in May of 2017. Ultimately, the Senate never came to an agreement on a proposal of their own. They looked at both the House bill, a bunch of other bills of their own. They were never able to pass a bill, and that culminated in John McCain's very famous thumbs down vote, late night vote at the end of July 2017. So after all of this repeal and replace, it became clear that there just wasn't the political will in the Senate, particularly, to move forward on a full repeal and replacement. So what happened next was what I like to call when tax reform met health reform, which is a horrible when Harry met Sally joke, but here we are. It's in my slides now. So the Tax Cuts and Jobs Act of 2017 mainly included tax proposals, but it did include one very important health proposal, and that was it repealed the tax penalty for the individual mandate with no replacement for it. So the individual mandate remains on the books. It is still technically a law. You are still technically required to have health insurance. The difference now is that when you go to file taxes, if you don't meet that mandate, you will have a $0 tax penalty. So on the one hand, that's a nice tax break. On the other hand, it's created some interesting consequences. The first is that without the mandate, some individuals are likely to go without health insurance. There are just some people who feel they do not need coverage without a monetary incentive to do so. So the Congressional Budget Office at the time estimated that the repeal of the individual mandate penalty would cause 13 million more individuals across the nation to go uninsured over 10 years, and it would also increase premiums by about 10% per year. What we're dealing with now, however, is a really interesting implication of the repeal of the mandate. And that's because it's serving as the basis for a court case. It's called Texas v. A Czar. It is currently working its way through the court system. This case was brought by about 20 attorneys general from red states who were challenging the constitutionality of the entire law on the basis of the repeal of that tax penalty. In December of last year, a judge actually agreed with those plaintiffs and struck down the constitutionality of the entire law, but the decision was stayed pending appeal. So for now, there are really no changes on the ground. The ACA is still there, but there is a possible court challenge that's currently working its way through. And just last month, in March of 2019, the Department of Justice filed a brief arguing that the entire ACA should be invalidated as a result of the repeal of the penalty. So it's still too early to see what's going to happen there. You've still got judges who are weighing these different briefs and figuring out their ruling, but this could potentially have huge ramifications if the ACA as a whole is struck down. So we will just have to wait and see what happens. But aside from that, we really haven't seen too much action in the legislative space lately. 2017 was chock full of healthcare action in Congress. Since then, a lot of the action on healthcare has been in the administrative space, the executive agencies in Washington, D.C. And they really have a lot of power to make significant changes to the law. So the first thing we've seen is cuts to pretty essential funding for the Affordable Care Act. First would be healthcare.gov marketing and outreach. This is sort of your basic advertising, letting people know when the open enrollment periods are and how to get coverage, that sort of thing. There was $100 million devoted to marketing and outreach in 2016. 2017, that dropped to $10 million, so that's a huge decrease. There were also decreases in funding to navigators. These are people who provide the direct enrollment assistance to people who have questions about their coverage or need some help getting coverage. In 2016, there was $63 million in navigator funding nationwide. That translated to about $2.2 million, supporting navigators in all 83 counties in our state. Last year, this was cut to $10 million nationwide and only $309,000 for the whole state of Michigan. This has ended up meaning that there are no federally funded navigators outside of Metro Detroit and Grand Rapids. So the scope and the power of these navigators to reach our whole state has been significantly reduced. There have also been several regulations that have come out that have attempted to expand coverage outside of the ACA. The first of these is known as association health plans. The Department of Labor issued a rule in summer of last year that expanded employers' ability to form associations among businesses for the purposes of providing coverage to their employees. So let's say, I'm a baker, maybe I've got a small bakery with 5 people. Dave is also a baker, he also employs about 5 people, as you do. We band together, we decide we're going to form a bakers association so we can provide one insurance product to all of our employees. Employers have had some ability to do this in the past, but this final rule really expanded their ability to do so. And more importantly, the rule regulates these plans as large group health plans. Essentially what that means is that they are not covered by some of the important rules of the ACA. So association health plans are not required to cover those 10 essential health benefits under the law. They can do some limited underwriting, changing premiums based on an employer's size, a location, or their industry. Now, they still are subject to some rules. They can't impose lifetime or annual limits on coverage. They can't impose limits on the benefits that they do cover. And they also can't underwrite based on employee health status. Now, all of this may end up being moot because at the end of March, a federal judge actually invalidated this rule. They said, Department of Labor, this is a direct quote, "This rule is an end run around the ACA. You have to go back and revise it." And so right now, the Department of Labor is in a position where they can either appeal the ruling, revise the final rule, or rescind the final rule altogether. It's unclear to me which of those paths they're going to choose. If it were, if I were a betting person, I would think they would either appeal or revise the rule, but we'll just have to wait and see what they do. But what I think is actually more impactful, outside of the association health plans, is another rule on short-term limited duration insurance coverage. This was a regulation released in August of 2018. And what it does is it expands the duration of short-term coverage from 3 months to 364 days. And it provides an option to renew that coverage for up to 36 months. So it's essentially taking short-term limited duration coverage and making it neither short-term nor limited duration. Now, the issue here is that short-term plans, you're really in a buyer beware situation because these plans are not subject to just about all of the rules under the ACA. They do not have to cover essential health benefits. There's no limit on cost sharing. They can impose annual and lifetime limits on coverage, and they can set premiums or deny coverage based on your health status or your pre-existing condition. Now, the flip side of that is that these plans typically have very low premiums, in fact, far lower than you would get if you went on the health insurance marketplace. But that's generally because benefits are very limited. In a recent study of existing short-term plans, researchers found that no plans on the market today cover maternity care. A majority do not cover outpatient prescription drugs or substance use disorder treatment services, and just under half don't cover mental health services. So this is a really, a caveat buyer situation. These plans may be okay for some people. You may need just, a short-term gap in coverage, a bare bones plan. Maybe you don't expect to use a lot of health services. That might be right for you. But on the other hand, if you do end up needing to use healthcare and you have one of these plans, you could be in a situation where you are not getting the coverage you think you were. So I could see that potentially having an impact in Michigan. Here in Michigan, we do limit the term of these plans to 6 months. So that is a state-based rule. The state has said that they really have no plans to revise that. So I think the impact here might be less than it will be in other states, but it's certainly something to be aware of. But the big change that has gotten a lot of attention in airspace, particularly in the past couple months, is in the Medicaid program. In January of 2018, the U.S. Centers for Medicare and Medicaid Services announced a really major shift in Medicaid policy. They now allow states to request permission to establish and test the impact of work requirements and community engagement requirements for adults who are considered able-bodied who are on Medicaid. Their argument here is that there's a relationship between work and health. They claim that requiring people to work to maintain their health insurance coverage fits the objectives of the Medicaid program because it will promote the physical, mental, and emotional health of the beneficiaries. So that's certainly one argument, and it's clear that there is a relationship between work and health, but what's not clear is the the direction of that relationship. It's just as likely that being healthy makes you more likely to work. Regardless, this is something that states have looked at for quite some time. There's been a lot of interest in implementing these requirements in Medicaid. There are similar requirements in TANF, which is the welfare program, in SNAP, which is the food stamps program. And up until now, the federal government had not approved those requests. But now that the switch has been flipped, we've seen a flood of states submitting these waivers to request permission from the federal government to implement these requirements. We've had 15 states submit waivers so far. 9 have been approved, although 2 were later blocked by courts. So on this list here, you can see Michigan is just about halfway down the list. Our work requirements waiver was approved in December of 2018, and they will take effect in January 2020. But to date, we really don't have that much experience with implementation of work requirements. It's really only been Arkansas that has had enough experience with implementing this program that we can, take a look at them and see how it's been working and maybe get a sense of how it might translate to Michigan. And the early experience from Arkansas has been less than promising. In 2018, over 18,000 people in Arkansas were disenrolled from Medicaid because they failed to meet the work requirements. A small portion of them, about 11%, regained Medicaid coverage in 2019, but it's unknown what happened to that remaining 89%. It's possible some of them may have gotten, employer coverage or another source of coverage. It's likely to me that many of them remain uninsured. And a lot of people have looked at the implementation of work requirements in Arkansas to see how things went and, try to do some early research. And they found several challenges in the implementation. The first is that it was very hard for the state to reach out to enrollees and educate them on these changes. They would send a letter that would either go to the wrong address, or we all throw out bills, and things like that we probably should open, but we don't. So the end result was that many enrollees were unaware of the changes or weren't, fully understanding of how they would be impacted and did not know what they had to do. The next hurdle was that the reporting process for these work requirements was only online. Every month, Medicaid enrollees had to go through an online system and record the number of hours that they worked each month. Well, that's an issue in the state of Arkansas, which is ranked 42nd among states in terms of broadband access. And to make matters worse, the website was open from 7 a.m. to 9 p.m. every single day. Outside of those hours, you could not log into the website to record your hours. That's an issue when you are maybe working multiple jobs, or you have, work hours that vary and maybe keep you away from a computer for a relatively reasonable time. Now, they've changed that since then. They've tried to make it a little bit easier for people to report, but we've still seen a really big impact. And the main issue we've seen, really doesn't relate to implementation. It's much more structural. In some places, especially in rural areas, there are just a lack of jobs, or there's a lack of transportation to get to the jobs that exist. So this is the experience we've been able to draw upon most recently. We do have a couple of other states, Indiana and New Hampshire, are going forward on their work requirements this year, so we might be able to see if their experience differs a little bit. But here in Michigan, we're preparing for these changes in our own system. In 2018, our state passed Public Act 208 of 2018. This change focuses specifically on the Healthy Michigan Plan population. So these are people who were enrolled in Medicaid expansion. There are some exemptions, people who are age 63 and over, people who have a disability or who are considered medically frail, people who are full-time students, caregivers, pregnant, recently incarcerated will all be exempt from the requirements. But if you're not exempt, then you will be required to, on a monthly basis, record 80 hours of employment, job training, education, internships, and a variety of other activities to maintain your coverage. There is a little bit of a grace period. If you can fail to meet these requirements for 3 months out of a given year. But after that, if you fail to meet it for the 4th month, then your coverage will be suspended for at least 1 month. And you can get back on coverage, but you have to already be meeting that work requirement. So these, this has been approved by the federal government. The Michigan Department of Health and Human Services is working furiously right now on an implementation plan to make this work. And the go-live date for these requirements is January 2020. So based on what we've seen in Arkansas and a little bit of past experience with work requirements and other programs, we have, if not a sense, at least some estimates of how this could play out in Michigan. Earlier this year, the Manat consulting firm published an analysis finding that about 400,000 enrollees out of the 700 or so thousand of people on Healthy Michigan would be subject to work requirements, meaning they would either have to report hours or actively obtain an exemption. The remaining 300,000, the remaining 40% or so, would be automatically exempt. Of that 400,000 who are subject to these requirements, each month, an estimated 174,000 people will be non-compliant, meaning they either didn't have the hours or didn't report them or didn't get an exemption. And so the cumulative impact of those non-compliant months means that over the course of 1 year, it's estimated that anywhere from 61,000 to 183,000 people in Michigan could lose their Medicaid coverage. This equates to about 10 all the way up to 27% of the Healthy Michigan Plan population. So this could potentially be a really, really impactful change on the Medicaid program. Now, there is some recent court action which we're keeping an eye on. It doesn't affect Michigan directly right now, but it's possible it could in the future. In March of this year, a federal judge blocked work requirements in Arkansas and Kentucky. Arkansas, of course, had been implementing. Kentucky was scheduled to start on April 1st. They no longer are doing that. Both of those governors have asked CMS to appeal that court case, and so CMS has done so. They've actually asked for an expedited appeal of the decision, and they're prepared to take it up to the Supreme Court, depending on the outcome of the appeal. So right now, this has no direct impact. Kentucky and Arkansas are in a different court region, so nothing changes as of right now, but if the Supreme Court does take up this case and rule on work requirements, that will be a nationwide ruling. So there's some possibility that this could impact Michigan. Whether or not it'll happen before January 2020 is a big question mark. We'll just have to see. Meanwhile, the irony of all this, and going back to our ACA 9 years on intro slide, the Affordable Care Act is more popular than it has ever been before. So this is a poll taken by the Kaiser Family Foundation, which is a health policy center. They do a lot of research and public opinion polling on healthcare. This was taken directly after the midterm elections in November 2018. And they found that 53% of Americans had a favorable opinion of the Affordable Care Act, while only 40% had an unfavorable opinion of the Affordable Care Act. This is the biggest gap between favorable and unfavorable that the law has ever seen. And ironically, the law has only gotten more and more popular over the past 2 years. All of these various changes to the law, whether that happened in Congress or in the agencies or in the courts, seems to have galvanized support for the law. And people have seen the impact of Medicaid expansion and of some of the other provisions and have said, okay, maybe this law isn't so bad. So while all of this is going on, there's definitely been a shift in public opinion in terms of the ACA. And so that's essentially where we are today. That's questions. I'll leave that for the end, unless we want to take some questions now.
You can take questions now.
Okay, great. I saw you got a hand up there.
I was curious, there was a claim made by Arkansas and maybe by other state governments that this would improve the health of people who were forced to work for their Medicaid. And I wondered if they had the foresight to check that, to show us measured improvement in the health of their Medicaid recipients.
Yeah, so that's a great question. So for folks who couldn't hear, you were asking, for states that have claimed that work requirements will improve the health of Medicaid beneficiaries, have they actually measured that? And what's nice about the Medicaid program is that all of these work requirements are being done under a specific federal authority. It's called a demonstration project. So they're actually required to test the impact of these requirements on the population. So every state does it a little bit differently. Every state has different plans for evaluation, but every state should be thinking about how this is going to impact coverage. Here in Michigan, this is a semi-answer to your question, so I hope you'll forgive me. But we have actually done some research looking at the sort of the work status and the well-being of people who are on the Healthy Michigan plan. And what these researchers have found is that Medicaid has really served as a support to help people work. Just about half of people who are on Healthy Michigan are currently working. The rest are either out of work, unable to work, or they're students, caregivers, etc. But for people that are working, Healthy Michigan has made them more likely to find a job, or more likely to have a better job, or more likely to do a better job at work. So when I was saying before, there is a relationship between health and work. But it's still, you can draw a lot of inferences as to what the direction of that relationship is. I think it's possible, certainly, that the people who are working may be healthier, but I think it's also possible that people who are healthier may be working. I don't know. I hope that answers your question.
Okay, I was wondering, particularly because Arkansas had the chance to implement this for 9 months or so, what their experience was.
Yeah, so that's a great question. I'd have to dig into their literature and figure out if they have measured any changes in health outcomes in their Medicaid population. What's tricky about this is that it's really hard to isolate the impact of one particular thing on the health of a whole person, and it takes a long time. So I'm sure if there's not something right now, there are probably plans for it, but it may be a couple years before we see that data.
Other questions? No, not really.
Oh, yeah,
So
go ahead.
you said there was a Supreme Court case in Michigan on this change in the
Not quite. There is a case working its way through the federal court system. It's not in Michigan. It affects Kentucky and Arkansas. So there's no direct impact on Michigan right now. There is a possibility that case, which is currently in the appeals process, it could get elevated to the Supreme Court. And if that happens and the Supreme Court takes up that case and rules on work requirements writ large, then that could have an impact on Michigan. But for right now, this case isn't really affecting what's going on here. Oh, I'm seeing questions. I don't know.
Yeah, go ahead.
Go ahead.
They say they have to work 80 hours
Mhm.
a month.
Mm-hmm.
But how are they supposed to find the jobs that will employ them for 80 hours?
That's a fantastic question.
I mean, maybe the government, maybe, they should offer employment in a courthouse or,
Yeah, so the
Instead of to prove that they're working, what's the pipeline to prove to the government that you actually have met that requirement?
yeah, so the question is, how are people finding jobs, and then how are you proving that you're actually working those hours? And a lot of
Does
these,
anybody have to work, or does somebody have to say, okay, you're able?
so there is, let's see if I'll go back to this slide. There are some exemptions, so certain people will be automatically exempt.
Right.
And a lot of this is like being worked out as we speak, so I don't know a ton of the details. The department's still kind of figuring out the processes. But what we know right now is that some people will be automatically exempt.
Sure, okay.
They'll have some medical claims in the Medicaid system that will indicate that they are, that they have a disability or that they're quote unquote medically frail. For other folks, I'm not exactly sure how they're supposed to be proving that they're working those hours. But the question about how to connect people to jobs is a real question, and it's something that states are grappling with, because states cannot actually use federal Medicaid dollars to provide supports for people to go to work. So they can't use funding from the federal government to help people meet these requirements. Now, each state might be approaching things a little bit differently. I know Michigan is really trying to make a concerted effort to link people to jobs. They'll probably have a partnership between the Department of Health and Human Services and Michigan Works to help connect folks to employment. And there are, some activities outside of paid hourly employment that people can engage in and still fulfill that requirement. So you could be a full-time student, that would count. You could be in an internship or in a job training program. You could also do community service, although that's only for 3 months out of the full year, so that's not like a permanent thing. But there are a variety of activities that will qualify towards that 80 hours. Yeah.
Does that include caregiving?
So there's an exemption for caregivers. People who are caregivers can, submit a form saying I'm a caregiver for X person. There are some rules as to who qualifies as a caregiver and how many exemptions you can have per household, but there is that provision in the law.
How many people did you say that would affect in Michigan?
So we don't know for sure. There are 700,000 people-ish on the Healthy Michigan plan at any given point in time. We think that about 300,000 of them will be automatically exempt. That leaves about 400,000 people that will either have to go out and obtain an exemption, submit some sort of documentation saying that they cannot meet the requirements, or they'll have to report their hours on a monthly basis. So
The jobs are just all of a sudden going to appear, all of a sudden, all the people are supposed to show that they're working. Okay.
yeah, so I think that's a question that we're going to be testing over the next couple of years is, how many people are actually being connected to employment as a result of these requirements. Yeah, go ahead.
Do the earnings from those 80 hours affect in any way their receiving benefits?
Yeah, so the question was, do the earnings from those jobs affect their ability to receive benefits? And there's definitely a possibility that they will. It's certainly possible that you could be working enough and earning enough that you are now over the income limit for Medicaid, in which case, you're basically disenrolled from Medicaid. You can get coverage elsewhere, but it's not always a given that that'll be a smooth transition. A lot of times when people are disenrolled from Medicaid, they're not sort of given that warm handoff to another source of coverage. So there's definitely going to be some churn in the market as a result of this. Yeah.
I just had a question on single pay when we get back to finishing
Okay.
up the years.
Oh,
Well-
any other questions from Megan?
On that happy note, I'll leave you to it. Oh, great.
Is there anything built into the ACA that you're aware of that can prevent, say, the Republicans and the insurance companies from dismantling it? Because I watched in 2010, I had my mother at my house, and in the beginning, there were a lot of other things in this plan. One of them was you could keep a parent or a loved one at home rather than send them to
Mm-hmm.
the nursing home. And they tore that right out. As I watched it, my mother was starting to get worse, and we were going to run out of money, I watched it, and sure enough, they just ripped it out, and throughout the years, if you watch, there's nothing that I see that can prevent.
So my understanding is, what are the protections to prevent changes, sort of major changes to the law? I think, and you bring up a really important point about, I think it was the Class Act, that was the sort of long-term care provision in the Affordable Care Act that got repealed later on. That's a big part of coverage that we're really not talking about when we talk about the ACA or a lot of other healthcare plans, and that's definitely a big problem that we're facing now and we're going to be facing in the future. But that aside, the protections of the ACA are really more in the structure of Congress than anything. So in the Senate, if you want to pass any major legislation or change any bills that have already been signed into law, it requires a 60-person vote to close debate on a bill and go to final passage. It's known as cloture. If you don't have the votes to invoke cloture, people can filibuster, talk forever and ever, and just like I'm doing now, stall the debate. So that actually ended up being a big protection to the ACA, because when 2017 came around, Republicans controlled the Senate, but they only had a 53-seat majority. So they did not have that filibuster-proof majority. That meant they had to go through a very complicated and convoluted budget reconciliation process to do all of their repeal and replace proposals, which meant they could only touch the parts of the ACA that were directly related to revenues and spending. That only required a simple majority. In the end, they couldn't even get that, so it ultimately ended up being not relevant, but that was a sort of a stopgap against some really major changes happening to the law, because they would have needed some support from the Democratic side to pass those changes, and that party was pretty unified in its opposition to any major changes in the ACA. So that's our deliberative upper body of government. Mm-hmm. In the back. Mm-hmm.
I saw on one of your slides a link.
Mm-hmm.
Is this information available online?
I think we can probably make it available. So at Chart's website, we do have a lot of, I don't know that we have this exact slide deck, but we publish a lot of issue briefs and fact sheets where some of this information is.
We don't have this, but you have a lot of very similar things to it, a lot like issue briefs, etc., which
Yeah.
are covering a similar area.
Mm-hmm. Yeah.
Which is why I asked in the first place. Any other questions for Megan? Oh. Okay, can we thank Megan? Thank you.
Thank you.
So, this is really an observation, but I've never seen anybody or anything look at the implications of single pay. So on my street, Haley, they're gonna put new water line in paving. So the city has to come in and look at my water meter. In comes this guy in his maybe late 20s. This terrible weather, he's had to go to all those homes on Hagen Street, the ice, the snow, wrist falling, the whole bit. So we got to talking. He hates his job, and why doesn't he leave? He's working for the city. What's he got? Medical coverage. And that's what is the only thing that's keeping him in a job that he hates. The implication being, when we get single pay, hey, I don't like my boss, he doesn't treat me well, I got my medical coverage, I'm out of here. So the implication is, there'll be a lot of movement amongst discontented employees, and they better start meeting some of their needs and requirements once that single pay goes into effect. So I just thought that was an interesting thing that I picked up and observed, that there'll be massive movement once we get single pay, or massive increase in benefits to keep people at work.
Yes, and
That was all.
as you're saying with what you're saying about the single payer, if that's where we end up going, taking away the what was originally an incentive back at the end of the Second World War to get people to come back into employment to these particular employers, is now something that holds them, captive in those employers. And I spoke to many people up north, both students of mine who are coming back and retraining, and for the very same reason, says, well, I want to retrain in this, but I can't lose my job because I've got my kids and I've got to have them covered, and many of them have children with chronic disease, etc. So they're doubly hamstrung in that system because of that. So it's a very good point. Yes?
So say you would put single pay like here in Michigan now.
Yeah.
You have all these different insurance companies, but they would remain, right? They would be able to remain?
It depends.
Again,
It's a very good thought. If you have a single payer system, the most common way to implement it is through taxation. So it would actually come, because it's essentially single pay is run by the government, it's mandated by the government, and it's the only large enough institution in a given state or countrywide which can actually implement something on that scale. The insurance companies, some are very large, but there's lots of little smaller players in there as well. I'm going to talk about this right at the end of this very short talk, so can we keep that one and then come back and remind me, if I don't come back to it, remind me, and I will, because it's actually a very, very good point.
This is related, so maybe we can make an visit at the end, but it is, of the single payer systems that are out there that you define so nicely, are there, has any of the three shown itself to be a step above the others in terms of either outcomes or benefit to cost ratio?
Just about to see it on the next slide. So, keep tuned. All right, that talk was fantastic. I really enjoyed that. It really helped to see exactly, particularly those first slides showing how many people were drawn into the healthcare markets thanks to the ACA. And I see that because I work up north in Grayling area, which of course, north of there's not a lot of jobs, there's not a lot of money sloshing around, and you see and hear an awful lot of anecdotal, painful stories related to their inability to access healthcare. All right, so we've looked at where we got, where we've come from. We've now looked at where we are just now, and now the last thing to really think about is a couple of current and pressing issues. So cost, the premiums keep going up. We can talk about some of the drivers behind that, and also look at some of the performance indicators in there as well. And I'm just keep this very simple because I'd rather generate discussion more than just throw stuff at you. So I'll just get stuck into that. So the American healthcare system is, by some considerable margin, the most expensive healthcare system the world has ever seen. You're number one, yes, we are number one on cost. So the argument is, if we're number one on cost, if you go out and you buy your Cadillac Escalade, and you've spent a lot of money on that, I have no idea how much a Cadillac Escalade costs, but it's more than I'm willing to pay. Or you could have your Buick LeSabre 2005, which I proudly drive around. Someone could argue, well, the Cadillac Escalade is a much better car, I'll get this much more reliable, your 2005 LeSabre will eventually fall apart, etc., which it may well do. But you've got an idea of cost and quality. In the American healthcare market, you should also have an idea of cost and quality. We pay more than anybody else for the same treatment. We're not talking about, oh well, I just had my knee replaced, and in America, I got diamonds on the side. You just get a knee. You get the same knee that a German will get. You get the same knee, an Australian will get. Why are you paying so much more for it? And is it going to be a better experience for you here getting that very expensive knee than the cheaper knee over in Germany, for example? There is a lot of statistics out there on this. Most of them all come back with pretty similar conclusions. In the last 20 years, an American healthcare market has been sliding down the scales of performance in terms of what they're actually delivering to the people that are paying for their services. The graph that's up there, table that's up there just now, is on the top line just looking at overall ranking of the major economic powers in the world. Now keep in mind, of the other 10 that are being assessed against, for example, take the country I was born in, United Kingdom, It's about 1/5 of the cost to do a procedure in the UK than in the US. Overall rankings, the NHS, which is often politically I don't know how you turn out the boogeyman, coming out of the cupboard to get you at night if you don't clean your teeth or something of that nature. The NHS, where you'll be left in the corridor to die, etc., and here in America that would never happen, and all of this is number one. It's falling down off there now because the Conservative government has been in since 2010, and every time the Conservatives get into power, there are our version of the right wing, they underfund the NHS chronically until it falls apart, and then they point the finger saying, look, it's not working, we should change the system. Yes, well, if you don't give them anything to work with, then yes, it will fail. And having worked in it under the Conservative governments, I've seen exactly, I've worked both in Scotland, where we have our own parliament and the Conservatives are not preeminent, and then worked in the English system where they are, and the differences were incredible in terms of treating people, and just the lack of sources, just looking for a butterfly needle to go, oh, well, we're a bit short of them. Can you use one of these, please? Something that dates back 20 years. So, there are problems in all systems, but the other systems are outperforming overall the American system. We're paying more for that. That's wrong. There's something going wrong there. So we need to actually start thinking about, well, what are the drivers behind this? So on this side where we're looking at performance indicators, care process, access, administrative efficiency, equity, and healthcare outcomes are 4 or 5 of about 15 or 20 indicators that you can look at. But if you look down the US column, which is on the end there, only care process are they about mid-table. Everything else, they're either last or second last. That's a damning indictment on the most expensive healthcare service in the world. So that was just there to really make that point, but it gets worse. I'm a real cheery guy.
Is cost built into maybe administrative efficiency?
Yes,
Okay,
absolutely.
all right, thank you.
But even when you look at satisfaction rate, again, you're paying a lot for a service. You expect to be pleased by the end of it. So you go to a fancy restaurant, you pay $100 a plate. You expect to have good food, be well treated, etc., and come out thinking it was worth your money, as opposed to going to McDonald's and spending $7.50, which I did tonight, for a Whopper, some fries, and a Diet Coke, which is going warm in my car. But satisfaction rates, same problem. The US has the least satisfied group, 29% of Americans are satisfied with what they have. Less than two-thirds are not. Sorry, you have a question?
It was interesting because I was wondering, how does that relate to the percentage that have their health care from their employer?
I was looking...
Really close, like as long as you have it from your employer.
Yeah.
Okay.
It's a great point, and I didn't find enough information to try and make that connection. But it would be worth looking into, particularly as we've just had the anecdotal story saying, I'm in my job because I need my health care. Am I happy with my health care? Well, it's all I've got. So I have to stick with it one way or the other. But there's a lot of discontent within the system about what we currently have. And that even given the fact that the ACA has done a lot more for people than what we had previous to 2010. And again, this terrible, terrible healthcare system that I trained in, the UK, 62% satisfaction. Well, maybe we're all crazy over there, and some of us certainly are. But still, a strong pushback on very perceived ideas often put forward by politicians in this country. So drivers in the market, there's a number of drivers that drive cost in the American system. If you listen or read some of the people on the right talking about healthcare, the one thing that you continually listen or hear from them is market forces. If you let market forces make the decision will be good. Market forces will drive it, they'll bring down costs. If you've got 5 vendors, all, let's stick with bakery because that was a good one. You got 5 bakers, everything smells nice and everything. You will make a decision between which donut you're going to buy based on cost and how it looks and things like that. You will, and by doing that, then one bakery may do better than the others, and that will drive down the price of those, etc. It has its natural processes. The problem within the healthcare market is there's no transparency in the cost of what you're paying. It's very difficult to even compare if you're going to have a knee operation at the hospital down the road or the one 10 miles further down the road, or which one's going to be able to do your knee for cheaper. It's going to be the same knee. And the problem with this is that because of the way the insurance markets are set up, so now we're talking about employer-sponsored insurance, even within the ACA is part of this, and just direct pay insurance, is that you're not just paying an insurer, you're paying the hospital, you're paying the doctor, you're going to pay the anaesthetist, you're going to pay a whole raft of other charges. You're going to pay a drug company you've never heard of who's going to be supplying the drugs to the hospital, which will then be used by, etc. And all of these are flying backwards and forwards. In an average procedure, you'll pay 6 different bodies for the one procedure that you have. In the NHS, you don't pay, you pay through your taxes, everyone gets paid the basic rate that the government is going to pay, and that's it. Take it or leave it. So the transparency of what you're going to pay doesn't exist. And even the right agree on this, that you need to make the system more transparent so people can make decisions. And I would agree with them up to the point of, if you could bring all of that darkness, take that away and then give back the actual ability to make a real choice about cost, then some of that would help. Some of those costs would go away. But the only thing that would happen is that to make the cost actually go away, you'd have to start practicing disintermediation, which is a word that I only learned about when I started looking into this. And this is essentially the process where you start pulling out the middle people who are not affecting your patient outcome. You go to the doctor, you don't go to 5 people first who know nothing about medicine and give every one of them $10 to go see the doctor after that. That's absurd. But that's what we're doing. We're paying all of these other people who are not going to make us any better than we were when we started the process, and they're all taking their money, and then finally we get to see the nurse or the physical therapist or whoever it's going to do that's going to help us.
Would that fix the problem of the fact that you don't really... my dad's knee just got replaced.
Yes.
That, in some level, is an elective. He didn't need it done, so we could, if we wanted, shop around.
Sure.
It's not like Best Buy. If I like this TV, but it's too expensive here, I can go down the road and I'm having a heart attack. Because I'll go to the hospital that's nearest, and frankly, I don't know how much they're charging because I'd rather live. Well, depending on how much money they charge, but
You might have another heart attack.
Yeah, exactly. So is there a way to address that in a system that's market driven?
Not really.
Okay.
No, and farming falls into the same group. Let me make the point. So the point that was being made is that because sometimes you don't get, if you have an elective surgery, you can make a choice. And then you can look at if it's transparent, you get to make that choice. If you're having a medical emergency, there's no choice. You go to whoever can help you first and fastest. So the same is actually true in the farming industry. It's a business, but it cannot fail, because if it fails, we all starve. So we can't run it as a pure business and drive everything down, although they try and do that in the milk markets all of the time. So there are certain adjustments that you have to make in these cannot fail industries. And so Haseeb makes a very, very important point, is that while transparency would help, and that would certainly make the people on the right very happy, it will not take us all the way there. So we want to bring out the middle people, and to do that we need to know who they are and then work out a slightly different way of doing it, which I'll get to in a minute. Sorry, you had a question I've been holding up.
Yeah, I think it's a great idea to be able to take that apart, but it requires, in a sense, a certain amount of cooperation from those who want to keep it clean.
Of course. Yes.
And that's what I wondered, is there almost like a business opportunity in terms of exposing what the actual cost is for a particular location, even though you might, the claim could be made, well, it's an individual's cost, and so what it's like, no, this is what they charge. A physical therapy at this place, my wife happened to have something recently, and it was like, oh, well, that's $750 for a session.
Yeah.
And it's like, she couldn't find out ahead of time. Oh, that's done through Mid-Michigan Health. We don't know what the charge is.
Mm.
And so then it was, you know, it must be reasonable. It's like, oh no, they can charge whatever they would like. Yeah. And it seems to me almost like if one just, in a sense, publish and shame them, not shame, but put pressure on them. Basically saying, this place charges $25,000 for fixing your foot. You know, this other place charges $20,000. This place, you know, same. In other words, bringing up that their reputation of charging excessive amounts puts them in a position where they would need to defend it or actually become transparent as to what the charges are.
No, I think it's a very, very good point. I've just been reminded that time is moving on, so I'm going to, you know, just push on. So, but the point you're making is the last part of the slide is identify the intermediaries, bring this out and make it more public would certainly have an impact on that. Drug costs actually overall have a smaller impact than you might imagine. This is considered to be 5 and 10% overall, but still, to the person paying the price of the drug, that's actually completely an irrelevant statistic because it's crippling for them. Again, America, a couple of statistics for you. All of the money paid to pharmaceutical companies in the entire world, America, with a population of around 350 million of about the 8.5 billion people we currently have, pays 45% of that. Again, the only country that lets the pharmaceutical companies set the price of all of the developed nations. And the key reason for this is because they keep the government out of the process. In the UK, in Germany, in France, in Spain, in Sweden, in Australia, in Canada, in Singapore, wherever you want to go, if you want to sell a drug there, you talk to the government. They will give you what they will pay. If you don't want to pay, then you can go somewhere else and sell in another country. It's done. So they have to just take what they can get, which is many, many times lower than what is put here. And I'll leave it as simple as that. We've got a whole issue brief on that. You can read some of the fun statistics that are in it. But it's really quite eye-opening to see just how much is being charged.
Is it true that drug companies cannot advertise in Europe?
Yes, it's true. They cannot.
Well, they didn't start here until about 1980s sometime, or we hadn't always had commercials.
There's a lot, I mean, it's a good point to raise. There is a lot of problems with having a pharmaceutical company trying to sell a drug to a patient because you are putting pressure. You know, ask your doctor about this medication. When I first came back to America from Australia in 2014, there was an advert for diabetes, for medication for diabetes, which of course is a very prevalent condition now in the United States. The drug I saw, looked at it and went, I don't because of they use brand names here, and I said, well, I looked up the brand name and actually got the drug class and went, well, that's odd. It's a fourth line drug. This means you use 3 other class of drugs before you ever get to this. It's rarely used because the other ones will get the job done. And I thought, yeah, I remember this from my med studies, and so I actually went back to my old notes and looked it up. You don't give this drug to people because its side effects are horrendous. It's one of the reasons why it's the 4th line, and they're selling it direct to people with this fancy advert of this person looking happy as anything, bouncing around. Go and ask your doctor about this. Please, can I have this drug because I'm feeling fine and my diabetes is uncontrolled, but I want to be happy like them. Anyway, so quickly finishing off, rationing. We keep getting told in America there's no rationing in American healthcare. Okay, point number 1. The only industrialized nation which definitely has rationings, you've got about 28 million people without any health care. So they've just been rationed out of the market because they have no access. One of the issue briefs that we've got on the website now is based around insulin. In recent times, insulin has been climbing and climbing in cost. There's only 3 providers in the entire world of insulin. And now it's become so expensive that people have tried to ration how much insulin they're taking because they can't afford any more. This has resulted in deaths. So again, I'm going to leave it there. That's just not acceptable. And it does exist in this market because of that very reason. Finally, the preventative approach. One of the things that gets ignored a lot in healthcare, consider what we're talking about in healthcare. It's misnamed. We don't give healthcare. We are reactive sickness care, is what we do and what we deliver. What we should be doing, and we have the knowledge to do, is to be real healthcare specialists in terms of looking after health before it is lost. And this is another part, and this will include the food industry, this will include the government, it will include the education side and all of that. But it's a very, very important recognition to make that it's time that we left the 19th century model of healthcare we currently are using and entered the 21st century about using the data that we do have and can collect to actually enable an individual to have the healthiest life they can manage. So if we wanted to change the system, I'm sure you're all quite happy, so we could just stick with no change. We can just have it as we are, and we can watch the premiums go higher. In Megan's talk, there was, the 10% increases and everything from the changes each year. It sounds quite a low number, but when you start looking at the actual physical costs, without even talking about deductible, that's a significant amount of money and increase, which is basically just continuously, gradually pushing people out of the healthcare market or pushing them toward Medicaid. We need to create transparency and lower drug costs, even if we don't change anything else. That would have an impact on the current system. But if we're not happy with the current system and we want to make it universal, we really kind of have two potential options without completely tearing the system apart and starting again, because believe me, that would be painful. Expanding Medicare is the most popular and in many ways the most sensible because it is government-based, so it's already got the foundation to move forward in the same way as other countries have gone from. And it's already covering a significant portion of the population. The framework and the infrastructure already exists, and it can be gradually expanded over a period of 10 or 15 years even. And during that time, you're just taking in another group of the 55 to 65, the 45 to, etc. Over time, it could be achieved. There are other ways around keeping the costs down, and there's a wonderful article shown to me by Ron Parmel, who's here tonight, out of India, and they have something now called Modi Care, or it's just coming into fruition. And of course, India, with over a billion people in population, doesn't have a universal healthcare system, and he's trying to create the first one, which is an amazing undertaking in a country the size and population that they have, and also the infrastructure they currently have. However, they're going to existing hospitals and medical groups and saying, well, this is how much we're going to pay, which is about a tenth of what they would normally charge. But many of them are actually still trying to work within that, and so they're changing the way that they work. So the upskilling part of that is where instead of having a surgeon come in for, just let's say, a gastric carcinoma, which is where the stomach is going to get removed, you're going to redevelop the duodenum into a Roux-en-Y and then have a fundamental stomach left after that. That's about 9 hours on an operating table with a break in the middle because you go in through the abdomen, then you come back in through the rib cage once you've collapsed the lung. That would cost, in the British system, it's about, I think it's about $20,000 to do the whole thing, to have the specialist surgeon there at all times. What they're beginning to do is they have the middle tier surgeons do the juniors open, the middle tiers make their way, they release the stomach, etc. And the actual consultant or top end surgeon comes in to do the actual things that need that top end quality. So he's only, or she is only in the room for about half an hour. And then once that's taken care of, the second in command comes back in, finishes, and the junior then closes. This allows this top surgeon to do 8 operations in a day under less stress than doing that one operation, which just about wipes them out completely. And having worked with surgeons and actually been assistant in those operations, I see exactly the toll that it takes on them. They look like they've been in a fight by the end of it. They just look totally shattered. Whereas reading the reports of what's been going on in India, these guys can do 8 times as much work and go and play a round of golf afterwards or whatever happens that they want to do, because it's much less stressful for them. Which again underpins the way that we're currently approaching our model, which is a 19th century model, may not be the best way for us to go forward. We could maybe actually restructure this to, one, keep costs down and actually make the job a bit more sustainable for the people in it. Most surgeons are retiring in their 50s because their backs and brains have gone. All right, well, thank you very much for listening. And if you have any more questions, I would like to try and answer them.
Once again, thank you everyone. Just give me 1 second.
Yep.
Megan has to leave, so if you could please give a round of applause again for Dave, I don't know how long you have, sticking around for a little bit.
I can, yes.
Okay, so I'm sure Dave would be happy to answer more questions about the system. Again, we have refreshments, feel free. All the issue briefs that you have in your hands, if you did grab a set, we have them posted on our website. It's mcp3.net. You can also access the website through our Facebook page or Twitter account. Everything's in Michigan Center for Progressive Public Policy. Please go there, like it, share our events. We'd like to fill this room with more people. Not that you guys are not lovely, but we'd like to see more faces, really spread this message, inform people about healthcare. Our next symposium will again send out information. We'll cover, it could be anything from labor rights to education, to maybe a deeper dive in healthcare into certain other areas, or I don't know. So we'll let you know, we'll keep you informed. And now you can take Dave as long as he's willing to stay and chat with him. You know, or question, take him, please, take him away. You know, I'll save him embarrassment during tennis. So ask any questions, and Dave is being very kind at this time. So thank you again for attending, and if you choose to leave, have a great day.